What I'm going to talk a little bit about today and just take you through a few examples are patients who have other findings besides just the Chiari. And we're going to talk a bit about spinal cord tethering and what that means, how you diagnose it, and also spinal instability, which can become a major problem for patients after they're operated on or even in the preoperative setting. So we'll go through and talk about a few of these things. So in terms of spinal cord tethering, spinal cord tethering is where the spinal cord ends up lying lower than it should normally be, the bottom of the spinal cord called the conus. And I'll have a couple slides to show this in a minute, but the conus generally ends up being at around L1. And when we see the spinal cord lower than this, we worry that there's potentially tethering. And it's not a very common thing in Chiari, but it's more common than I think most people think. And reports in the literature say upwards of 15% of Chiari 1 patients can actually have tethering. And tethering can be due to what we call a fatty phylum, where there's fat elements in the phylum terminale. Or the cord can just be low with no other clear abnormalities seen on imaging. And you can actually see lipomas as well, and there have been a few studies that have said the incidence of lipoma in Chiari 1 is as high as 2 to 5%. And these are not big numbers, but when they're there, it's a particular entity that needs to be addressed, and oftentimes addressed before you actually do a Chiari decompression. And again, spinal cord tethering can occur in a fair number of cases. So what is tethering? So oftentimes when we're looking for tethering just in the general neurosurgery setting, we're looking for various things on the physical exam. We're looking for odd dimpling around the gluteal fold, what people sometimes call tails or little appendages that can be there. Back pain is a common finding. So oftentimes when we're seeing patients who may have non-classic Chiari symptoms and fit into this category, we're going to be looking at the imaging critically to see if there's a low-lying spinal cord. They can have leg pain, bound bladder disturbances, motor deficits, sensory disturbances, sometimes atrophy in the legs. Again, these are uncommon findings in the setting of Chiari, but are sort of the red herring things that we want to look for. And the way we figure this out is by the history physical exam, most commonly on the MRI, and sometimes with urodynamic testing. So again, I mentioned that we consider an abnormally low spinal cord to end somewhere around bottom of L2 or L3, and certainly if it's below this level, it's considered abnormal. Most of these studies have come from cadaveric studies looking at normal subjects and seeing where the spinal cord typically ends. There have been a few publications out there in terms of fatty phylum and trying to categorize these. I'll list this below here just for reference, but basically there's, just for fatty phylum alone, still a lot of controversy in terms of when to treat these. And then you add on top of that Chiari and you'll get a variety of different opinions. So again, this is a patient that we treated for low-lying spinal cord. There's a dimple that's a little bit high that you can see in the right-sided picture, and then the imaging studies on this patient demonstrated that the spinal cord was a little bit low, the phylum was thickened and had some fat in it. The two pictures on the, the picture on the left and the picture in the center are different patients, but both presenting with similar symptoms and findings. So what do you do when you find this? So typically what we're going to do in our practice is if we see a patient with a Chiari and there's a low-lying spinal cord, have a discussion with the family about these two different entities, and oftentimes in my practice I'm going to offer them a detethering procedure first and see what that effect has if they have a syrinx and if they have a Chiari. And the way this procedure unfolds, I'll show a little bit of an intraoperative photo on the left. What we do is the patient's positioned prone. We bring in X-ray to confirm the level that we're going to do a small laminectomy or take the bone off the back of the spine at one level. We're going to go down, expose the dura, which is a thin leather that covers the brain and spinal cord, open that up, and then identify the phylum. Typically, you can just visually identify an abnormal looking phylum. It has fat in it, which you can visualize. It's often thick. But on top of that, we typically will do neurophysiologic monitoring, meaning we're doing spinal cord monitoring to ensure that we accurately can monitor the patient, make sure we're not causing any injury by the surgery, and we can stimulate the phylum before we transect it to ensure there's no neural tissue in there. And so that's the example on the right here. We've identified the phylum. Prior to cutting it, we do the electrical stimulation, cauterize the phylum, and then cut it. A lot of times you'll see that once you cut the phylum, it separates and basically springs apart, and that's oftentimes a nice indication that we have got a phylum that's under some tension. And then everything just gets closed up. Dr. Ellenbogen and colleagues here a few years ago published a paper on acquired Chiari with a fatty phylum. And so there's sort of this chicken and egg debate as to whether or not a tethering spinal lesion can lead to Chiari. That is very controversial, and people take both sides of that argument. But just as a case report that came out of our institution demonstrated progression of Chiari malformation in a known tethering patient. Again, with tethering, there's been quite a bit published on the topic, and this particular paper was looking at tethering and Chiari 1 malformation. Out of 110 detethering patients, only 7% had a Chiari. In this, in 6 of 8 of the total number of patients were symptomatic from that lesion. So it's not a particularly common thing. One of the questions that comes up just with Chiari decompressions and with this type of surgery is, once you do the surgery, is it a durable result that you're going to get, or is there a chance you're going to need to be reoperated on in the future? And one of the nice things with detethering, especially for a simple phylum transection that we were talking about, the risk of a retethering procedure being needed is extremely low. It's about 2% or so in the literature, and personally, I have not had to go back on any of these kids. Spinal lipomas, again, very uncommon in Chiari, but in the literature it's reported somewhere between 2 and 5% in Chiari 1. The picture on the right shows a very large, obvious lipoma in the low lumbar region. A lot of times it's not as obvious, or it's intradural, and you're not going to see any external stigmata of the lipoma. For just lipomas in general, male to female ratio a little higher in females. Again, you can see cutaneous stigmata, and so when the physical exam is being done, that's obviously the most important thing probably that we do at the beginning, and you want to look for any soft tissue masses, dimpling hemangiomas, tufts of hair, or other things on the examination. The bottom picture here on the right is looking at the dura being opened and the lipoma that's sitting on the surface that was ultimately resected. Again, presentation is often atypical compared to a typical Chiari patient. They can have lower extremity motor dysfunction, urinary problems, back pain, leg pain. Similar findings to what you would see with spinal cord tethering. This is an example, again, a little bit bigger of that patient I was showing earlier. You can see as the dura is open on the left frame, the lipoma. This is a very delicate operation when you have the lipoma involving the nerve roots and spinal cord, again, using spinal cord monitoring and a variety of microsurgical neurosurgery techniques to safely remove this without injuring nerve roots or the spinal cord itself. This is a very different operation than just doing a phylum transection. One of the things that's come out recently that our institution helped popularize and has been a big advocate of is the use of a carbon dioxide laser. It's a relatively new product that came out in the last few years and has, I think, really revolutionized our ability to tackle lipomas with much lower risk to the patient. So we've been leading the way, I think, with some of these technologies and introducing them, especially in pediatrics. So the way I manage these, and Dr. Ellen Bogan does similar in most cases, we're always going to want to have a spine MRI. So oftentimes the patients will come in and they will just have a brain MRI. We always want to get a spine and ensure that we're not missing something that's part of the equation in the way the patient's presenting. So we want to see it, make sure they don't have a syrinx. We want to know the level that the spinal cord is ending to make sure it's at a normal level, that it's not ending low. And then we're going to be looking for any associated abnormalities. Is there fat in the filum? Is there a lipoma? Are there any other abnormalities seen on the imaging that may change the direction that we go? Maybe we would treat the tethering before we would tackle doing a Chiari decompression. So for me, the way I handle this is for treatment, usually I'll address the spinal abnormality first, especially if I think it's causing tension on the spinal cord. I'll give the patient a period of time to recover, and then we'll repeat imaging. And we're looking at if they had a syrinx, has the syrinx had any resolution? Has the Chiari improved? There's certainly been some case reports where you do a detethering, and over time the Chiari elevates. That is exceedingly uncommon, but that has been seen. And are their symptoms improved after that first procedure? If so, you may hold off on doing the Chiari decompression. I'm going to switch gears a little bit and talk about craniovertebral junction abnormalities. And so what this entails is instability of the upper cervical spine. The occiput attaches to the spine, and there's a very complex set of arrangements of ligaments and bones that keep everything nice and stable, allow you to have appropriate head movement. And it's not an uncommon thing, as we're recognizing and looking for this more often, to see on imaging, even as a patient's first presenting, abnormalities at the craniovertebral junction. And these have some very serious consequences potentially if there's abnormal motion or the spinal cord is at risk or impinged. I think as we're beginning to understand a bit more about Chiari malformations and the ultimate cause of it, whether it's a mesodermal problem or what the exact genetics of it are, that ties in actually to some of the theories about craniovertebral instability. And so there's probably going to be a joining of some of these theories as we learn a bit more. But again, it's, I think, very early, unfortunately, in our understanding of all this, but some of this will be hashed out over time. So the way I think about craniovertebral junction abnormalities, they can be congenital malformations. Things didn't form right. The way the bones generally will come together and fuse doesn't happen properly. This can happen at the occiput, at the atlas, the first cervical vertebra, or at the axis at cervical vertebra number 2. And it can lead to a variety of different, very odd, challenging congenital abnormalities. You can also have developmental and acquired abnormalities at the foramen magnum, and obviously in Chiari we talk about the posterior fossa being too small. Dr. Millerat's talked quite a bit about the size of the foramen magnum. So these, again, all these things tie together. And then general instability can be seen in a variety of different syndromes, Down syndrome, Morque's, Hurler's, with a variety of these different type of childhood and adult diseases. So what we're doing when we get all these studies at the beginning is really looking to see what the anatomy is. And so typically the patients are going to come in, if they're being evaluated for Chiari with an MRI, it's less common for them to show up with a CT of the cervical spine. And some of the things that we're going to assess on those pictures are what is the anatomy of the brainstem and the spinal cord at the cervicomedullary junction as the brainstem turns into the spinal cord as it exits the skull. Is there a buffer of spinal fluid anterior or posterior to the spinal cord? Is there any impingement anterior or posteriorly? So as an example, the lower picture on the right is an MRI, and you can see on this study that the top of C2 is actually impinging backwards, or retroflexed odontoid is what we call this, into the brainstem. And this is obviously not a great thing, and patients can sometimes present with very significant symptoms from this: ataxia, motor problems, swallowing difficulties, cranial nerve dysfunction. So many of those symptoms that you hear or are part of the textbook for Chiari can actually come from these ventral compressions that we see. When we have an MRI that looks like this, we want to follow up and get a CT scan and actually really understand the bony anatomy. And there's a variety of different measurements that we use that I won't go into in the talk today, but basically what we're looking at is the position of the cervical spine relative to the skull and the clivus, basion, and the tip of the odontoid. And what you see in this patient is the base of the skull is actually right here, but jutting through the foramen magnum is the tip of the odontoid process, and so it's actually going up into the brain. We call this cranial settling, platybasia. There's a variety of different terminologies that are applied. So this is something that we don't like seeing and usually ends up getting treated in some fashion or another, which we'll talk about a bit more. Dr. Menezes has been a leader in this area for a number of years and has really taught many of my predecessors and sort of my current generation a lot about spine surgery and how to stabilize the spine. This is a paper fairly recently from 2008 in the Journal of Neurosurgery Spine by his group, just looking at patients who've had hindbrain herniation with or without Syringomyelia. This is looking at 234 patients, and in this study they found a variety of congenital abnormalities, Klippel anomalies where there's fusion of segments of the cervical spine, Down syndrome, simulation of the atlas, basilar invagination, and a variety of these complex spine disorders that ultimately, in his hands, went on to undergo fusion procedure. This is an example out of this particular paper, and you can see that as the patient flexes the head forward, the odontoid actually impacts into the brainstem, and so this is pretty easy to imagine how this causes problems. Dr. Millerat, as everybody knows, has enlightened our view of Chiari with numerous publications over the years with a huge series of patients that he's treated. This is a publication of his from 2007, again in Journal of Neurosurgery Spine. One of the points that he makes is a lot of these patients may have connective tissue disorders, and again that feeds into the concept of, you know, how does Chiari actually come about? What are the root causes, the genetics behind it? And looking at his extensive series of over 2,800 patients, a fair portion of those, over 12%, actually had Ehlers-Danlos or some related hereditary disorder involving connective tissue. And so in those patients, those are the patients who are probably highly prone to occipital cervical instability, and cranial settling, where we get impingement at the foramen magnum. In an earlier study of his from 2009, out of 364 patients, 12% had presented with basilar invagination, 5% with atlas assimilation, and another 5% or so had abnormalities of the cervical spine, such as Klippel. He makes a commentary in his paper here that, you know, these numbers may be a little bit high because of his referral patterns, but I think the point of the talk today is that as practitioners, these are things that we need to be looking for, especially when the patients first present or as we're following them long term to make sure that they don't develop these abnormalities. Again, in his paper, quite eloquently went through a variety of different ways to assess for instability at the occipital-cervical junction. Again, I won't go into details today, but we're looking at a variety of different measurements and anatomic regions right at the base of the skull to see if there's separations, abnormal distances, abnormal positioning of the bones relative to one another. Again, from his paper, looking at those 357 patients out of the 2,400 or so, very high proportion had Ehlers-Danlos with hypermobility. So in the last couple minutes here, I'm going to show you two patients that Dr. Ellenbogen and I have been involved with. This is a patient that we are currently treating, and it's a very interesting case because it shows sort of the progression that you can have of this basilar invagination over time. And so what I want you to pay attention to, in her, she has a syrinx in her spinal cord. Her cord ultimately on imaging was a little bit low, so we thought there was tethering as a component